Hi, thank you for everyone for joining. Anyone who has questions, go ahead and put them in the chat or feel free to ask your questions now. Any of the physicians that are on here, if you'll just give a quick introduction so people know who they're talking to, that would be great.
For me, so, well, now it's afternoon, but good afternoon, everyone. I'm Ara Metchin, a hematologist, currently at the University of Colorado in Denver, have a very strong clinical and research interest in TTP. Thanks for everyone for being here.
Hi, I'm Ming Lim. I'm at the University of Utah, so just next door to Dr. Medjan. I'm an adult hematologist with a focus in hemostasis and thrombosis.
Hi, I'm Yara Park. I am actually not a hematologist, but they let me in this session anyway. I'm a pathologist who specializes in transfusion medicine and blood banking. I run the apheresis unit in the blood bank at the University of North Carolina in Chapel Hill.
I'm Keith McRae. I'm a hematologist at Cleveland Clinic, and have enjoyed working with this group.
I'm Satish Chonad. I'm a pediatric hematologist at Children's Healthcare of Atlanta and Emory University, and with certainly interest in TTP.
All right, well, thank you everyone for joining. Does anyone have questions now? This is meant to be kind of a potluck catch-all question and answer session with a variety of physicians here to answer any of your burning TTP questions. So if you had any questions, especially on relapse that weren't answered in the previous sessions, I know there was quite a few for that, feel free to ask away. You can chat them in if you don't feel comfortable talking on camera, or if you'd like, you have the ability to unmute yourself and be able to discuss with the physicians.
Hi, I'm Amy from Virginia. In the last session that we just had, a number of people in the chat indicated that they have Hashimoto's disease in addition to TTP, and I have that as well. And I'm curious if you have seen any correlation with Hashimoto's and TTP.
Well, I guess I can start off. I have not, but you know, it actually doesn't surprise me. I've certainly seen cases of TTP in association with many other autoimmune diseases, because I think there's basically, all these diseases represent, you know, an underlying predisposition to developing autoimmune disease, one of which is Hashimoto's, one of which is another type of thrombocytopenia called ITP, which I've certainly seen several cases that patients have had at different times, either TTP, usually ITP evolving into TTP, but sometimes vice versa over the years in different episodes. So I would have to, you know, look through the literature, but it wouldn't surprise me if there were not some coincident cases. I don't think there's a strong correlation, but I'm not that surprised by hearing your experience.
It looks like in the chat, there's also a question about what's the ratio between men and women for TTP? So do you see one sex being affected more than the other?
I can take this one. We definitely see more women, at least here in North Carolina. Probably 3/4 of our patients are women compared to men. And that's not unusual for a lot of autoimmune diseases.
All right. So here's another question. They were diagnosed with TTP back in 2014 at age 59, and at that time their Adams TS13 was less than 3%. They haven't had a repeat level. Would it be reasonable to expect to get another Adams TS13 measurement?
I can take this. It's Raj Kasturi at UNC. Hello. So it depends on people's practice. I think it comes down to there aren't any strong guidelines that recommend at this point that serial Adam TS monitoring need to be pursued in everybody. I think as long as the CBC is being checked and the platelet counts are okay, the value of adding an Adam TS13 to that is still being studied at this point. It's one of our interests as a group within this consortium too. So it's very user dependent. I do check it at follow-up visits in my practice. But again, if people don't, I don't think that's necessarily wrong. It does. Era or Keith or anybody else, do you feel differently about that, or?
I guess my argument would be that based on some of the discussions earlier today and my own experience, I do think that I think that there is. I think the individual who asked this question has had a great experience to go for 6 years now with 3% Adam TS13 and not relapse, though certainly people can do that, obviously. But I think a low Adams TS13 in that range does definitely predispose you to be more at risk for a relapse than if your Adam TS13 was 50% or 60%. And I think some of the data that Dr. Catalan showed earlier this morning did suggest that, and from the several groups in France and wherever, that the preemptive treatment of the low Adam TS13 with rituximab will reduce that risk of subsequent relapse. So my practice, I'm a little more aggressive, I think. The farther out someone is from a TTP episode, the less frequently I check. But I usually do check, and I mean, my practice is to treat people preemptively with rituximab when their levels of Adam TS13 go below, 15-20%.
Yeah, can I
Arguable,
clarify?
of course.
Can I clarify one thing, Keith? I think I understood the question to be the Adam TS13 level was 3% at the time of diagnosis of TTP, but following recovery from TTP, it was never checked again. So we don't know what the Adam TS levels are at remission or in remission.
Yeah, I think maybe I interpreted incorrectly. Yeah, if it was, my answer was directed towards if you had recovered from your TTP and someone found you then to be asymptomatic and have a level of 3%, which would be a much different interpretation than Raj raised.
So when in an acute episode, you don't feel like there's need for serial Adams TS13, but if you're in remission further on, it may be beneficial to kind of monitor the levels and look at a trend. Is that what I'm gathering?
Yeah.
That is my practice, yes.
Yeah,
Okay.
I think we both agree on that. Yeah.
Perfect. Okay. Here's an interesting question. Is there a home CBC machine, like a glucometer? And if not, do you know of one in development? And do you think it would be beneficial for patients to have access to that?
I'll field that one. I'm unaware. I know that there are, as you mentioned, a home glucometer where you can check your sugars at home. That's very common for diabetes. For some of our patients who require to have their blood thinned with the medication Coumadin or warfarin, there are also machines that can do this at home. But as far as I know, there is not a home CBC machine that is either currently developed or currently available.
If there was one, do you think it'd be beneficial for patients to be able to check their CBC every day, or do you think it may cause more worry than it would benefit to have that knowledge?
So that's a good question. I'm not sure if we know the answer. I think Currently, our practice is just because of what obtaining a CBC involves with coming to an office or coming to a facility, having a vein, a needle placed into a vein. We tend to do it only on, especially when someone is further along or further out from their acute episode. We recommend that only, on an as needed basis. Certainly, it would be very useful if someone had symptoms that is consistent with their relapse. They'd be able to check themselves at home. If such a machine was available, it would definitely save them a trip to a doctor's office, an urgent care, an emergency room. But yes, there's always that concern that someone who is constantly checking, we know that with other testing modalities, that this can increase the levels of anxiety and concern because it's always being checked and people are waiting on the results.
Okay. Let's see here. Well, there's people wanting an appointment with you, doctor. And then let's see here. Recent blood work for a non-TTP appointment showed that the GFR was at 57. Up to now, it's been in the normal range because the GFR have changed due to TTP.
Well, I would say it's possible, but it's hard to know without more information. That the GFR is a somewhat, a little bit crude estimate of renal function that can be variable from time to time, but generally does indicate some renal dysfunction. But of course, that can be from many different things, such as high blood pressure, diabetes, many other things. So I would say that it would be unusual for you to develop kidney dysfunction in the setting of quiescent TTP or TTP in remission, if this was just a routine medical follow-up. It is true that the TTP can affect the kidney. Usually, most of those effects occur during an obvious clinical flare or clinical event that's identifiable as TTP. It's not impossible for TTP to affect your kidneys in the background, but it probably would not be on the top of my list. And at the very least, you should be evaluated with a clear perspective for all the possible reasons by which your GFR may have dropped.
Okay, so here's a genetic question. Is it known what gene TTP or the issue with the AMSTRS13 is on, or what chromosome it's on? So this sounds like it would be more important to the patients with congenital TTP. Satish, if you want to take that.
It's my question, but
Oh, yeah.
it's not for congenital. I was diagnosed with the acquired immuno one, but I have a daughter with a genetic diagnosis and genetic abnormality. And through her diagnosis, she's going to be eligible for a full West testing and looking at what clinical significance we can see in that. That's kind of where I'm going with that one.
Yeah, no, it's one of the few proteins where the name of the protein and the gene is the same. So it is the ADAMTS13 gene.
Wow, I didn't know that. Thank you.
It's a good question because sometimes you can get confused. I believe the chromosome is 9 in humans. And yeah, I see a few head nodding. So I think that's the case.
And I'm not writing down because I'll forget it. Guarantee you, I will forget.
So to clarify, a child has ADAMTS13 genetic defect or some other genetic?
No, she had other genetic duplications.
Okay, thank you.
It's sometimes a little bit hard to interpret some of that because you can have some mutations, and there's all kinds of different mutations you can have, and some are pathogenic mutations, and some may be what we call silent mutations, which is a mutation that doesn't cause disease. I mean, I've had a couple patients that confused me for a long time because they appeared to have acquired TTP. They had a very low level of antibody detectable and a low functional level. But they did have antibody, and the antibody was inconsistent. When I did genetic testing, I found a potentially pathogenic lesion. So sometimes in some diseases, you can get an abnormal protein produced because of the genetic mutation. And you can probably develop antibodies against that abnormal protein because it is abnormal. So it's sometimes a little bit difficult to tease that out. But if your child is getting West, I think that's a great.
Yeah, she does have her genetic abnormality is illness, but she does have issues from it. So,
Okay.
but again, so it's one of those things that I know that's the direction we're going. So I would call this sheer curiosity. So I thought it would be a good question to ask, because we as her parents have not been tested to see if it's how it all works together and what mine is. So I was kind of curious, and her geneticist wasn't sure on the TTP relation to the genetic makeup. So that's why I thought I would just kind of throw it out here to y'all and see what you came back with. So thank you.
Yeah, great question.
Here's another interesting one. So when this patient when they're in a healthy state, their platelets run very high, like 450 to 550. But during relapse, they drop down to 12 to 20,000. Is it unusual to have such extremes with TTP? They're wondering if they were potentially misdiagnosed because their ADAMS TS13 was normal when their platelets were 20,000.
I can start, and then others can jump in too. It would be interesting to know whether, as part of the TTP treatment, this person has had a splenectomy, because people who've had splenectomies tend to run platelets on the higher side, and that could be the reason why, when they're in remission and TTP is not active, the platelet counts are on the higher side. It's not uncommon. I struggle to reconcile how we diagnose in today's day and age TTP in the setting of normal ADAMS activity. So we'll need to learn more about that. That's typically it's almost the diagnostic test or the criteria you have to meet, at least for what we call acquired TTP. Thoughts from others?
I guess. Oh, sorry.
Go ahead.
Okay, I guess my question would be, I don't know if we have more information regarding kind of her presentation, is, when she's presenting with those severe episodes of thrombocytopenia, what are her other lab parameters other than the ADAM TS13 showing? I mean, with the hemoglobin and peripheral smear, is there evidence of microangiopathic hemolytic anemia, or is it just the isolated thrombocytopenia? Because if it's just the isolated thrombocytopenia and the ADAM TS13 is normal, there's a potential that this is a different disease process that we're currently dealing with. So I don't know if there's any further clarification on that.
I'll address, I'll say that it's not uncommon for us to see we've seen patients who've had a rebound thrombocytosis where the platelet count goes above 450, which is the upper limit of normal. That is not a shock. And even we've seen with patients who've been treated with caplacizumab, that number goes even higher, 600, 700. So to go from one extreme to the other is not a shock. And it's not surprising, and it's not something that I've ever done something about, just to merely look at it, nod my head politely and say, there it is, from one end to the other. But I will echo what Dr. Kasturi said, is having a normal ADAM TS13 in a setting of profound thrombocytopenia does raise the question of whether or not this is TTP. Now, it's possible it may have just happened once. It could have just been a simple mistake, especially if there were other tests that showed very low levels in absence of ADAM TS13 activity. But that is something that would require another look.
Okay, thank you. So what side effects does rituximab have in the long run? This person receives it every 18 months, and they just want to know what the safety profile looks like. Mira or Ming, I didn't know if one of you guys wanted to take this one.
I mean, I could take it. So I mean, in patients where I've used it more chronically, overall, the side effect profile is generally well tolerated. I think what I worry about when I'm using it more chronically, I worry about maybe more of the rare side effects. Sometimes we do see some rituximab-induced neutropenia, and so in someone that's using more chronic, frequent doses, that would be something that I'm always going to be surveilling for. But otherwise, if the patient has otherwise tolerated the infusions itself, typically people don't experience long-term side effects. Another rare side effect I've seen, again, very rarely, are some neurologic manifestations, but again, they're so rare that I wouldn't I wouldn't tell a patient not to take rituximab because of it, but I would counsel them on that.
Okay, and just follow up with the patient who was diagnosed with the normal Adams TS13. She has the high platelets when she's healthy. She hasn't had a splenectomy. They drop down to 12 or 20 during TTP episodes, but during the diagnosis, when she was diagnosed with TTP, her Adams TS13 was at a normal level, and the blood smear showed hemolytic anemia, and she was anemic. She had low hemoglobin, but that was her general presentation. So maybe you guys, if you guys want to have a discussion on what doctors typically look like to diagnose with TTP and how, what you need to exclude prior to saying the patient has acquired TTP.
Well, I agree with what some of the other folks who weighed in on this have said, and it is unlikely, or certainly less likely, that this is TTP when your Adam TS13 is normal and you have significant thrombocytopenia. I mean, that said, I mean, there's a few patients described in reports said to have TTP with normal Adam TS13 levels, but I've never been quite sure exactly what to make of that. They respond to plasma exchange and so forth. But, there's other immune diseases, for example, ITP, which is antibodies directly against your platelets that can cause low platelet counts like this, would respond to the same treatments that TTP does, plasma exchange, rituximab, steroids, and would lead to, when it recovers, potentially an overshoot of the platelet count, as Dr. Metchian, I think, mentioned, which I see also. In terms of the hemolytic anemia, there's different kinds of hemolytic anemia. The ones that we look for in TTP is something called a microangiopathic hemolytic anemia, which is a certain type of hemolytic anemia where I think, I forget whose presentation this morning showed a nice slide showing how your red blood cells get broken into pieces, and the pieces are called schistocytes that we can see on the blood smear. But there's many other kinds of hemolytic anemias, and one of them that can go along sometimes with ITP is called autoimmune hemolytic anemia, where you have antibodies not just against your platelets, but against your red blood cells. And when you have ITP and autoimmune hemolytic anemia together, it's sometimes called Evans syndrome. And again, both of those things may respond to steroids, to rituximab, to plasma exchange. So the response to treatment also is not diagnostic of TTP. So it's hard to really be sure. I agree that sometimes this high platelet count can be a rebound from an episode of thrombocytopenia when your bone marrow is continuing to make a lot of platelets to compensate, but the process that's eating the platelets or destroying the platelets is quenched. But it's still, I think it's hard to make that TTP diagnosis. It's a little bit hard for me to buy into that with a normal Adam TS13. But again, as I mentioned, there's a couple cases people have argued that are TTP with normal Adam TS13. I don't know what other people's thoughts are on that.
Just to add on to that, there is also drug-induced TTP. Usually when people present with drug-induced TTP, you identify the culprit medication, and the solution is to stop the offending medication. But sometimes I've seen people, when you're not sure and you're waiting for the ADAMTS13 to come back, you start treatment with plasma exchange and steroids first, and then the ADAMTS13 comes back normal, you stop the plasma exchange, by then you've already stopped the offending medication for a few days. So it's still called TTP, but it's more of a drug-induced TTP kind, where you could get a normal ADAMTS13.
All right. So is there a correlation between the level of severity of the initial TTP episode and the number of relapses or the severity of a relapse? So if your first episode is really bad, are you at higher chance for worse episodes down the line?
I can answer that. As far as I'm aware, there is no correlation between that initial event and if and when someone relapses. Right now, as we know, the most significant predictor of someone having a subsequent relapse is whether or not that ADAMTS13 inhibitor remains. That we, as Dr. Mazeppa said in his presentation, while we know that you need ADAMTS13 deficiency, we know that that is necessary for TTP. What we still don't know in 2020 is that we know that it's not sufficient. As has been mentioned, there are many people who walk around with decreased levels, low levels, absent levels, and they are still not in a state of thrombotic microangiopathy or TTP. But as far as we know, the only thing that predicts a future relapse is whether or not there is an absence of ADAMTS13 activity. Anyone else have thoughts on that?
No, I agree with Dr. Metchin. That's been,
Thanks.
I'm not aware of any data on this, and it's been my experience as well in my own practice that the severity of the initial event has not been a factor in predicting whether the patient relapses or not.
Okay, good. Oh, here's a great question. What is the best way to approach your hematologist or local hematologist that aren't knowledgeable on current treatments or prevention of TTP about further education to keep patients safe when they're your only treating hematologist? So how would you guys recommend that discussion go, and what are some points that they may be able to bring up?
So I guess I would preface this with, I work at Mayo Clinics, or a huge referral center, and I will have a lot of patients who will come, not necessarily from their referral from their hematologist, but just because they wanted to see me or see someone at Mayo. And usually in this situation, the home hematologist is more than happy to discuss with us our recommendations, because if they truly are unfamiliar with the disease process, as a physician, you're going to be looking for the best for the patient. And so if someone can offer them guidance on a treatment that maybe they're more familiar with, most physicians are very happy to collaborate and take those recommendations. So I guess when speaking with your physician, and you could always just broach them and just say, is there an opportunity for me to meet with an expert, or go to a larger academic center where I could just get an opinion on different treatment approaches. And I would kind of broach this to the rest of the group, but I think most physicians would probably accept that as an option, and give you options for ways to approach that. But I didn't know if anyone else could comment.
Yeah, I would just add on that for all the badness that this coronavirus epidemic has caused us, one of the things that may be a positive is that it forced a lot of institutions to really seriously adapt telemedicine. And I would venture a guess that anybody in the audience could probably get a virtual consult with any of the TTP doctors who are participating in this in the USTMA. you know, that's probably true, I would guess, but certainly most. And because, you know, I'm personally seeing about 20% of my patients still with just virtual, you know, Zoom visits. And, you know, it would be a good way to approach your doctor too. Say, hey, you know, I wonder if I can I'm just curious. I want to learn more about TTP. And there's a expert at the University of Colorado. And, you know, can we send him? I live in, you know, Western Utah, and you know, it's a long way there. And can we just send him my records and let me get a virtual visit with him? And then that expert at University of Colorado will send back a detailed note with all his, with some education in it and some good treatment plans. And I think that actually helps people a lot who may not have direct access to a tertiary medical center.
Yeah, and another reason that can be brought up with the treating physician for an opinion at a tertiary referral center or within our consortium or people who specialize in providing for TTP is we have research studies that are open that the patient may be interested in participating that are not necessarily accessible to the primary community hematologist. So that's another opportunity that would exist at a tertiary referral center potentially, and we certainly want to enroll as many patients as we can in research studies. So there's another reason why.
I think those are great points. So here's a question about congenital TTP. Is it connected to hormones? This patient had a 14-year remission and then it came back. So just with either acquired or congenital, are you aware of hormone fluctuations or changes impacting the disease process?
I can start with this and maybe somebody else can add on. I'm actually not directly aware of any association with hormones in congenital TTP, but certainly conditions such as what we know in congenital TTP that pregnancy certainly is a time period, especially in the early few weeks, to trigger a congenital TTP even for the very first time, which we believe that the inflammation of the stress might increase that protein, that glue-like protein that Dr. Catalan was talking about called von Willebrand factor, which kind of sticks the platelets to the lining of the blood vessel. But I'm not sure in terms of the ages you're talking about. So I don't believe there's a direct correlation. And I don't know if there's any studies done looking at the various hormonal levels or so. With regards to acquired TTP, we tend to see that in this younger age group as well, that we've seen mostly half of them definitely have a clear underlying autoimmune disorder, which there are some studies in lupus and so on, is it happens during a hormonal changes in their lifetime. But I think it's a bit of a far stretch for me to really connect those two, to be honest. I don't know if others have any thoughts on that.
There we go. I was trying to unmute myself. I think I agree with Satish in terms directly. There's just a point of clarification for someone who has a congenital TTP. The ADAMTS13 deficiency will always be there. It's something that person was born with and they're going to live with. Now, and I think this references a question further down, what causes that second, third, fourth hit? What else causes for them to then manifest with a thrombotic microangiopathy? We don't know. As Satish definitely mentioned, we know that pregnancy is a very well-known, very big, what's the word I'm looking for? Precipitating event where we often will see that come to light. But hormones themselves, I have to say, I don't know if someone, let's say, was starting testosterone supplementation, or if someone was taking birth control pills, or if someone was on hormone replacement therapy due to menopausal symptoms. I'm not aware of those hormones, so to speak, if I'm understanding the question correctly, leading to an exacerbation or a relapse of TTP.
Okay, perfect. So what percentage of patients do you think have had multiple relapses? So the patients that have had multiple relapses, what percentage of them do you think have issues with depression or anxiety? Or how often do you hear about that in your practice?
I don't think D Darrell is on the call right now, but she'll be the best person to answer this. She could probably give you a better idea on what the prevalence is. But I will say that given the nature of the disease and the unpredictability of it, it naturally causes patients and myself as well a lot of anxiety on, because the biggest questions they have asked me is, when will this recur? What am I doing that's causing it? And a lot of times I have to reassure them that there's nothing you're doing that's causing it, and we still don't know what are the provoking risk factors that may trigger your ADAMTS13 to drop and then increases your risk of TTP. So I would say that the prevalence of anxiety and depression is high in itself, and it's one of the questions I often ask my patients: how are you coping with this diagnosis, and how's your family affected as well?
Okay, thank you. All right. So earlier in the day, we heard about the second hit trigger for TTP. So that idea that there needs to be a secondary thing in addition to ADAMTS13 deficiency to cause a TTP episode. Would a severe emotional event be considered a second hit? And could something like that, like emotional stress, trigger a TTP episode in an already deficient patient?
That was my question again. Okay, I got another. Um, I spiraled down after the tragic death of my little sister. And that's what I started to really have the symptoms and everything. But I blew it all off because of stress. But that was when I can say I started to have the issue, really starting to notice the bruising and this, and within 2 months, I was in the hospital. So that was it. And my ADAMTS13 it hasn't been checked, but even after remission for 2 years, it still didn't break 50%. So I was curious if that was, because you're always looking for what caused it. What was a trigger? Could that have been it?
That is, for people, I mean, we see this in people who have suffered big, life-threatening, scary diagnosis. The reactions say, shoot, was this leukemia, cancer? Was this lupus, my heart attack when I had these symptoms? That is our innate natural reaction to go back and see what could have caused this. The car accident, the death of a loved one, this trauma that I suffered. We see this. Our patients tell us this all the time. And what's kind of tough for us to say on this end is we see the exact opposite, where people have said, what the frick? I was doing so great. Life was sunshine and lollipops and rainbows and unicorn. And then all of a sudden, darn it, I'm back here again seeing you. So I don't know. I don't know what the answer to that is, because we know that there's very few people who aren't stressed. And if stress was a risk factor for disease, holy smokes, all of our patients should be in the hospital or in the ICU. So, we don't know. All I could say is I hear that, doc, do you really think that when I got fired, do you really think when I lost my mother, do you really think it was when I fell and broke my leg, this could have happened? Yeah, it's possible. But I also say, on the other hand, we see patients who, this has gone away for 5, 6. I had one patient who relapsed with their TTP over 20 years later, and it was just out of the blue. So I don't know. But yeah, I don't know if anyone else has any other thoughts on this.
It's a really good question. It's a fascinating question. You know, I remember when I was in medical school, I did a project on sort of mind-body thing, and there was someone who studied that a lot, a famous guy, I think his name was Hans Selye or something, that studied the relationship of stress and disease and had some really fascinating correlative data. It's a little bit probably out of most of our expertise, but clearly stress can induce physiological changes in your body in terms of cortisol levels and all kinds of other things. And it is not inconceivable that stress may precipitate in some people TTP, but that said, probably not all. I mean, it's not by any means the only thing, but it's hard to say with certainty that it doesn't, frankly, for me anyway.
Thank you.
All right. So here's a question. African Americans are the highest group affected by TTP. What do you guys do, or what is being done to make the patients feel listened to and to feel heard? So anyone who wants to take that.
I could certainly start off with it. I think it's a great question. I practice here in Atlanta, and we do have one of the largest number of children who have a diagnosis of lupus, and majority of them actually are African American. And the same thing actually goes with many other blood disorders, including TTP, that we have seen, at least with acquired TTP. So I think it's an ongoing challenge, especially with the current climate. And I think, like every physician, it's important to listen to the patients, and more importantly, also listen to the parent, is what I've always been taught. Because many of the times that by the time when you're seeing the child in the clinic, they're usually bouncing, the chairs and the tables, and many of the times you have a tendency to actually say a child is okay. But I think it's important to listen to the parents who have seen the child for years along at home. So I think it's important point. It's also important to I encourage parents to actually write it down, video it, take pictures, so that you can actually discuss this with your providers, and don't hesitate to ask them the questions if you think they're not listening to. Don't hesitate to call back and follow up with the nurses. And I think it's important to actually also use your, you are the best judge, and you are the best person to know about your child. So I always encourage parents, do not hesitate to ask. Sometimes, unfortunately, it does require more times that you ask. But as a physicians, I think we also kind of realizing the fact that some of these patients are not listened to. So I think there's also, as a community, at least I can say from here, we're doing a lot more changes to be able to minimize that, for lack of better words, the disparity.
I would like to also jump in here if I can. I'm not a hematologist, but I am a methodologist. And I'm also Black. So I think I would say that implicit bias is real, and it means that sometimes providers don't recognize that they have an implicit bias, right? And so just like Satish just said, if you don't feel listened to, you have to push. You have to either keep going to that doctor or recognize that you might have to go to another doctor. And we've had patients tell us that their doctors told them that they probably just have the flu and to go home. And when they got home, they felt worse. And that's when they went back to the ER. And a lot of times it is that push where you know something's not right. And so you don't just say, okay, I'm just gonna wait. Go ahead and if you can't go to that doctor, go to a different doctor, and just keep going until you're listened, until someone hears you.
I'll add that the symptoms of TTP are usually very vague, but what I've seen from my patients, especially the ones who've had relapses, they know themselves very well, and they know the symptoms of their relapses and of their TTP. And like the others have said, you just have to advocate and keep pushing because you know yourself better than anyone. But you know, implicit bias is a thing and we have to fight it and keep working on it. But yeah, it's a tough diagnosis to make. We all see it all the time, so we can recognize it, but sometimes it's more difficult for other physicians who don't see it as often.
All right, unfortunately, that is the end of our time in this session. Any of the questions that were chatted in, we will save and try to work into any other sessions. Or if your question wasn't answered and you'd like it to be answered, please just email it to the admin@USTMAconsortium.com email address, and we'll work on getting those answered. Join us back at the main link to continue on the patient meeting. And we really appreciate you sticking with us through the technical difficulties. I do apologize about that. Thank you for everyone who joined.